Good evening and welcome to the Voice of the People. My name is Lois DeMayo and I'll be hosting the show this evening. And I have my good friend here, Dr. Jeffrey Berkley. Good evening, Doctor.
Good evening.
Dr. Berkley is from Connecticut Oral Surgery. And we thought we'd get into oral surgery and explain it to the people. A lot of people don't realize there's something after the dentist. Many dentists refer to oral surgery anyway. But to start off with a short biography, that's short.
That's my cue. I'm originally from Chicago, and I went to University of Illinois. I've been in Connecticut for over 30 years, practicing oral and maxillofacial surgery, and 4 kids. Grown up now, though. I'm old now.
Tell me about it.
Yeah.
What made you decide to go into oral surgery?
I was math science oriented, but I also liked art. And there's not a lot of careers that can combine artistic development with like the creative aspect and then also the intellectual aspect. It's not a lot. And dentistry was one of them. I think it's one of the best careers for that type of person. So that's what I went to dental school.
Okay, and then from there on, you had extra education?
Well, when you graduate dental school, you're a general dentist. And then I did pretty well in dental school and wanted to do something in the specialty end. Oral and maxillofacial surgery is, I'll say the elite aspect. It's really not. It's a cooperative aspect of dentistry where it has a very wide scope of practice. We do everything from facial reconstruction to taking out a tooth to putting a tooth back like an implant. And that was very interesting to me.
Okay. A lot of people don't realize the oral surgeons, I mean, you fix facial fractures and orbital fractures, and a lot of people don't realize that. They think they have to go to a regular surgeon for that.
Well, we are kind of the regular surgeon. We're a cross between a medical doctor and a dentist. We do surgery on pretty much anything from the neck up. We do, well, just for instance, we might do tumor surgery that's a cancer. We might do tumor surgery that's a benign tumor. We do broken jaws. We fix those. But we also do a lot of dental procedures, taking a tooth out, doing a bone graft when someone's missing some bone in the jaw, putting an implant in to reconstruct a missing tooth. So it's a combination of all those things.
Okay, we're gonna take all of those things, one by one, and give people the definition of these. Now, in oral surgery, you are allowed to sedate a patient. So, what are your choices? If I came to you and I wanted a tooth extracted, what are my choices of how to do it?
Well, the tried and true conventional way, but not actually the most popular way anymore, is to just get the Novocaine shot that the dentist gives that numbs your mouth up. It kind of makes your face feel like when your foot falls asleep. And that allows you to work in someone's mouth without causing pain. The problem with just giving Novocaine anesthesia is it doesn't take away pressure on the jaw, vibration, kind of like when you get your teeth cleaned, and nervousness. And those things aren't necessarily painful, but they're kind of annoying. People don't necessarily like them. So the next step up in the ladder is Novocaine and laughing gas. You breathe laughing gas through your nose. The stuff you see on YouTube is a little bit fake. I mean, it doesn't make you go crazy and things like that. It just relaxes you, makes you not care as much, raises your pain threshold. It makes you think that what you're doing is easier than it really is. The next step above that is still getting Novocaine and laughing gas, but now you're adding in an intravenous portal, and we give medications through that vein that makes you sleepy, it makes you more unaware. We sometimes call it twilight sleep in lay terms. You're still breathing on your own, but you actually think you were asleep. You get done and you say, well, like, wow, when'd you take my tooth out? I don't really remember that happening. There's a step above that one where you actually give such deep anesthesia that the patient's not breathing, that you're actually breathing for the patient. Usually that type of anesthesia, I call it hospital anesthesia, but it's the kind of anesthesia that you would get for most major surgeries in a hospital setting. It's usually done in a hospital setting, but can be done in an office setting. And it used to be more popular. I think nowadays a lot of patients don't like the idea of not breathing in a dental office to do something that they could have even done with Novocaine. So the most popular anesthetics are those middle choices, the laughing gas and the Twilight Sleep.
I've seen how effective that is when they wake up and wonder when you're going to get started. You know,
Sometimes they don't
have
believe you
all
did it
day,
yet.
you know. How are you going to get started here? Okay, let's take the simple extraction. Is that usually a referral from a dentist, or 2 or 3 teeth?
Yeah, it is. The term simple extraction, I just take that as a point of discussion for 1 second. I'm not sure there really is such a thing as a simple extraction. The books say there is, and that sounds great until it turns into not a simple extraction. So a simple extraction is one that doesn't require cutting, doesn't require a stitch. You just come in, we wiggle the tooth a little bit, and the tooth comes out. And ahead of time, sometimes it's not so easy to predict what's going to be a simple extraction and what's not going to be a simple extraction. But those are usually referred by the dentist to the oral surgeon because they feel like they need the added expertise of the specialist.
Okay, yes, because sometimes I'm sure a tooth breaks, or a root tip breaks, you know.
So when they're a broken down tooth, they turn into what's called a surgical extraction. And it's kind of just the way it sounds. It means you might have made an incision, maybe you put a stitch in, the tooth probably came out in pieces. It doesn't necessarily mean it's that much harder for the patient. They get more nervous about it because it's a surgery, a bigger deal surgery, but it really isn't. I find that most patients do equally well with a surgical extraction and a routine extraction.
Okay, and then you use a drill for that, a high-speed
Sometimes
drill?
we use a drill. We have to take away some bone or divide the tooth into pieces. People get a little freaked out sometimes when you say you're going to divide the tooth into pieces, but if you think about it, pressure on the jaw is one of the annoying things of taking a tooth out. If you divide it in pieces and you're taking littler pieces out, it might take a little longer, but it's less pressure on the jaw. So I don't think for the patient that it's necessarily that much harder, but obviously for the surgeon it's a more complicated extraction.
And I'm sure with the Twilight Sleep, you know, starting the line, that there's instructions given to this patient ahead of time.
Well, you better give the instructions ahead of time, because if you give it after the fact, they may not remember it.
And those are
Well, I mean,
strict fasting.
to have a sedation in an office setting or a hospital setting, anybody who's had that knows that they have to not have anything to eat or drink for a certain period of time before surgery. It's usually 6 hours. Sometimes people think that's a long time to fast, but if you're doing it in the morning, you basically get up and come in and do the procedure. It doesn't seem like it's that hard to fast. If you're trying to do it at the end of the day, it's a little bit of a chore. And you need a ride home. If you're having sedation, you're not driving yourself home because you're considered impaired. But there's not that much to it. There's very few additional instructions to be able to do it with sedation.
And with just the laughing gas and the Novocaine, they recover on their own? They're able to drive themselves home?
With laughing gas, you're allowed to drive yourself home. That's surgeon dependent. There are surgeons out there who require their patient to have a ride home even if they had laughing gas. But the truth of the matter is, laughing gas wears off in basically 5 minutes of breathing oxygen. So the things you see on TV where people are reacting on their drive home, either a fabrication or they really didn't have laughing gas. They had something more than laughing gas. Sometimes people will couple laughing gas with oral medications that can be sedating, and so that obviously lasts longer. But laughing gas wears off pretty quickly.
Okay, yeah, those ads you see on TV, how did they even get them downstairs and into a car when they're
Yeah,
that bad?
I take issue with most of those things you see on the internet because I would say very few of them are true.
Yeah. Okay, let's to reconstruct a jaw, a fractured jaw. That takes wiring, right? I see
It
people
used to
with these
take wiring.
wires.
We now use something called a bone plate, which is made out of titanium, and they even make some now that are even dissolvable, made out of polymers. And you basically put the pieces of the bone back together into their correct position, and you put some screws into the jawbone that hold the plate in its place. It holds the bone rigidly in its place while the bone heals, and then the bone has mended itself. It's not really any different in the jaw than it is in the leg or the arm. It's the same basic concept.
Okay, so they don't wire all the teeth.
Well, so
I know they used
in
to
the
that.
old days, and still sometimes currently, people don't necessarily like the idea of a bigger surgery with an incision and a plate that's put into their jaw. There are fractures that are less severe, and you can actually just take the teeth, bite into your bite, wire the teeth into a fixture that lets them be closed. You can't open and close your mouth. You're wired shut. They call that being wired shut. But it's really kind of like putting braces on your upper and lower teeth. And then you know how the orthodontist puts a little rubber band on that may move a tooth? Well, this is a lot of rubber bands, so it makes the jaw really not be able to open and shut.
Oh.
And now your jaw, because it's not moving, it's the same concept as the plate. It holds the jaw in position and allows the bone to heal. Less invasively.
And what about an orbital fracture?
Orbital fractures, I don't know if the audience knows what an orbital fracture is, but the orbit is the bone that goes around the eye. So any of those bones that break can create both a cosmetic disturbance and a functional disturbance. Sometimes they're severe enough where they can alter vision or cause double vision. And in cases like that, we have to put the pieces back together. The problem with the orbit is the bones are very thin, so you can't always put each bone to each bone with little screws because there's just too many pieces. So you have to kind of mold it together. But when there's bigger pieces of bone, we do the same thing. We put a bone plate on and hold it in its position.
And this would be done in the hospital setting,
That's a
wouldn't it?
hospital surgery, yes.
Okay. As far as root canals, I know oral surgeons don't do them anymore now that there are specialists, right?
There is a specialist for root canals called an endodontist, and they do root canals for patients. The oral surgeons do certain procedures related to root canals. Root canals have a certain percentage of the time they don't work, they fail, and some of those cases can be corrected by doing a surgery that gives a better seal to the end of the tooth, the part that's way up in the bone, so that the root canal would then work. That surgery can be done by oral surgeons. Not too many oral surgeons are doing the actual root canal themselves. So in the old days, we used to do them when the patient required sedation, because a lot of the endodontists don't do sedation. But nowadays, I mean, root canal is a procedure that most people don't do with sedation. They just use Novocaine, and that's why the specialty of endodontics has come about, and they do their own root canals.
Well, a lot of time, I'm sure you need the cooperation of the patient too. So
For everything we do, we need the cooperation
you
of the
need them-
patient.
Yeah, right. You know, wake up now. Staff, let me see. In your practice, there are several offices.
Yes, my practice has several offices.
Um,
We have offices. I'm trying to build a network of offices that can service the entire state. We're not quite there yet, but we have an office in Fairfield, we have an office in West Haven, in North Haven, and in Meriden, and out by Stores in Mansfield near the college. And we have a couple others in development that may be happening soon, trying to geographically represent the whole state.
Okay, so now you have to train the staff for all of these offices, right?
Yes.
And how many doctors are in the group?
Well, we currently have 7. And as I said, we're growing. So that, if you ask me in a year or two, that probably will be more.
Yeah. And then you got to watch out for the ones that retire, right?
You know, what's really nice, if you're in group practice, I mean, sometimes group practice gets a stigma because we're used to the old days where one individual doctor was in a practice. And that day still exists, but it's getting harder and harder to practice that way because there's so many things involved. There's government regulations, there's scope of practice, how many different procedures you can do, and there's the training and everything that goes into the staff. And so larger practices are starting to have an advantage, and that's certainly what I'm seeing. So I think the trend is that way to the larger practices that can be able to accomplish more procedures, more depth of care than what individuals could do in the old days.
And staff must be easier to acquire at this point because of all the schools that are teaching assisting, which
I'm going to
they
say
didn't
yes
used
to that, but
have
I'm not
that.
so sure that that's the truth. So there are lots of staff out there, but we're trying to attract the very best staff, and there's a wide range of how people are trained and how intimately they're trained. And a lot of times the schools are training someone to be a chairside assistant in a general dentistry office only. So they may apply for our position, but have to be trained all over again because they really don't know anything. Oral surgery is not quite the same. And there's many specialties in dentistry. There's pediatric dentistry, there's orthodontics, there's endodontics. So the assisting for those, and even the front desk work for those, is different from specialty to specialty.
I can remember years ago, where there was one oral surgeon around, and that was Dr. Coach.
Yep.
And then he took in Dr. Bauer and then Dr. Rosen after that.
Yep.
Dr. Rosen had his own practice at the time, but then
Eventually joined
he
us.
joined them, and then eventually joined you.
Mm-hmm.
And that's where I came along, right? He's relaxing in Florida,
Fishing.
Thursday is fishing. Tuesday was golf and got rained out. So he used to sit on his back porch and watch the golf course and laugh at the guys golfing.
I don't know if I'm ever going to get to that. I don't know if I would. I don't know what I would do with myself. I've always been driven to work. Mm-hmm. I think they're going to carry me out one day. I don't know if I'm ever going to be able to
You're
retire.
You're going to stay for the long
Yeah.
run, right? Yeah, right. Okay. What causes swelling after an extraction?
Swelling is caused by an inflammatory reaction. So the cells in the blood release histamine. The histamine releases fluid. Fluid goes into the tissue, causes swelling. And some swelling actually comes from bleeding that gets into the tissue too. If you think about it, you close up the wound tight, and if there's any oozing underneath, where's the blood going to go? Sometimes it comes out, sometimes it goes like into the cheek or under the tongue. But that's where swelling comes from, is an inflammatory reaction in the tissues. And it's not necessarily a concern. The other type of swelling that people get is actual infection. And that's where we have to differentiate the difference. What's just swelling because of the surgery, and what's an actual infection that might need treatment?
Oh, that's true. And with wisdom teeth, Your swelling occurs on the bottom teeth more so than the top teeth, right?
Well, that's how it presents, and I think it presents that way partly because of gravity. I mean, if you get swelling in the upper teeth, this space is continuous. So the swelling up here eventually ends up down here anyway. And then you get swelling from the lower teeth, and where does that go? Well, that's down here too. So I think when people are doing 4 wisdom teeth, they get more swollen on the bottom because that's where it all goes. But I think you get swelling from upper teeth too. The bone on the lower teeth is also thicker, so it takes more surgery, more insult, which causes more inflammation when you're doing a lower tooth than an upper tooth. And so they do get more swollen for that reason also.
I have a granddaughter that lives in California, and she came all the way here to have, I think at that time, Dr. Rosen extract her teeth because Mim will take care of me. Well, by the time we got her home, she went into my freezer. And I said, Anna, what are you looking for? And she says, I got them, never mind. 2 bags of vegetables. And she put them on, and she took the Velcro strap off her suitcase, put it on her head, and she was hands-free.
What a great idea.
But she's the actress, you know. She'd go to the front door and somebody come to see her while she was here. I don't always look like this, you know. Yeah, so, you know what I found? They molded much nicer.
Yes.
And they refreeze much quicker.
They have ice packs that you can buy now that are kind of like gel packs.
Yes.
That do the same thing, but they're not cheap, they're more expensive, and the vegetable packs work just as well, I think.
And you can't use them after, right? Why don't we get into the replacing of teeth? I see you have several models here.
I brought them because I think people have a hard time conceptualizing and visualizing what a tooth replacement is. Sometimes they think, oh, you're taking an actual tooth and sticking it back in their jaw. I've actually had people ask me if I plant a little seed in their jaw and it grows a tooth.
Oh.
I mean, we've run the whole gamut.
Really?
Replacement of teeth nowadays is usually done by something that looks kind of like a screw and is made out of usually titanium, although they also have them now in ceramic. And you prepare a site in the jaw, very precise, down to the fraction of a millimeter. You put this implant into the jaw, and then you let the bone of the jaw heal to the implant. And with the new surfaces that implants have, 20, 30 years ago when we were doing this, it was all smooth, and they didn't really bind to the implant. But now they actually grow into the little nooks and crannies of the implant and bind to the implant. The success rates have gone up accordingly. And so tooth replacement now, what's interesting is I get the question, which I don't know if you were going to ask me, but I'm going to ask it anyway. That people come in and say, can I do a tooth replacement? Somebody told me I can't, or something like that. The new modern techniques, the answer is always yes. It's not, can you do the tooth replacement? It's, how difficult is it going to be to get there? How many steps, how much cost, how much logistics to get there? And you have to ask yourself the question, is it worth it to do a tooth replacement? But not, can I do a tooth replacement? So, is it worth it to do a tooth replacement? My answer would be yes. When you're missing a tooth, I have a lot of patients that come in and say, oh, no big deal. It's just one tooth, I can still eat. And the answer is, you're right. But just think about the mechanics of losing a tooth. When you lose a tooth, where does the force from that tooth go? It goes to the tooth in front of it. It goes to the tooth behind it. It probably goes to the same tooth on the other side of your jaw. And so then you have to ask yourself, how strong are those teeth? If those teeth are perfectly good, strong teeth, they're probably going to handle that force. But what if they have fillings or crowns or gum disease, and they're asked to take that extra force? You could be causing other teeth to be lost because they're being overloaded. Also, you can get tooth drifting, and if you're missing enough tooth, you're going to definitely notice, I have people tell me all the time that they notice that they can't chew as well. But just because you're missing one tooth doesn't always mean you can't chew as well. But those other things we just discussed are always going to be there. And they're good reasons to do a tooth replacement. God gave you X amount of teeth, 32 teeth, and I'm not going to question the fact that those teeth should be there. I think it's better that if you have them than if you don't have them. Now, I mean, some people don't want to go through the time and expense of replacing them, but I think even insurance companies are starting to recognize that. They never used to cover replacements. Now many companies are starting to cover replacements.
They are, huh?
Yeah.
That's what I was going to ask you about, insurance.
Insurance is tough because insurances now don't want to cover anything. Even stuff
Right.
they used to want to cover, they don't want to cover now. But replacement teeth in the form of implants are starting to be covered by, it's about time. They used to call it experimental. They were calling it experimental even after we've been doing it for 20 years. Now we're doing it for over 30 years. They're not really calling it experimental anymore. They're just saying they either cover it or don't cover it.
Right. Now, some teeth, I would say, would not be good candidates to replace. You wouldn't replace the wisdom teeth.
We haven't found great use for wisdom teeth anyway. I mean,
Where's
if
the
they-
wisdom of it all?
Well, I charge extra to transplant the wisdom back into your body after I remove the wisdom tooth. Now, I think that the only great use for a wisdom tooth is when you're missing a bunch of other teeth and the wisdom tooth is the only thing you have left to chew on. But I think the average patient who nowadays keeps most of their teeth, to have a tooth that doesn't fit in your mouth, that's difficult to clean, that can harbor germs, that can actually spread to other teeth, cause decay, cause gum disease, doesn't make sense. And then certainly wisdom teeth that are impacted, which our jaws are getting smaller and smaller. If you look back in caveman days, they had fourth molar teeth, not third molars, and they usually fit. They had that big jaw. Nowadays, I see people coming in, sometimes even their second molars don't fit, the tooth in front of the wisdom teeth. But very few people, at least in the US, have wisdom teeth that fit. When they don't fit, then you're prone to infection, or they try to force themselves into the mouth, which means they could shift the tooth in front of it or even damage the tooth in front of it. And we know that that's going to happen 80% or more of the time. That's the
Really?
statistics. I mean, that's not 100%, but it's a number that is certainly big enough to justify removal of wisdom teeth in situations where the risk is relatively low. And the risk is relatively low for most people under age 30. When you start to get over age 30, if you haven't been having problems with your wisdom teeth, a lot of times we'll just watch them unless they cause a problem. But be aware that there's a good chance they're going to cause a problem. If you're under age 30, I would probably just get most people would just get them out.
What about a partial? Is there anything that would be suggested instead?
Well, partials don't have anything to do with wisdom teeth, but they have to do with implants and tooth replacements. And when we call it a partial, in lay terms, that's a denture that doesn't have all of the teeth. It's not a full denture. It's a denture that only replaces some teeth. Now, it's not for everyone because they come in and out of the mouth. They clip on your other teeth, which means they're putting force on teeth that may not be able to take that force, and sometimes the teeth they hook onto loosen or are lost over time. Partial dentures don't always feel like teeth. They don't always look perfectly like teeth. But a well-made partial functions reasonably well. And the advantage of the partial, I can think of two right off the top of my head. One, you can get them pretty quickly. So implant reconstruction sometimes takes months and months to get to an endpoint. But a partial denture might take a week or so, and sometimes they can even prepare it ahead of time. So as soon as we take the tooth out, you can get it in. The other thing, a partial denture is going to be less expensive.
Yeah.
So from a cost standpoint, there's an advantage. But those, actually, in reality, those are probably the only two advantages I can think of.
Okay. When a patient comes to your office, sometimes they will bring x-rays from their dentist.
Mm-hmm.
Are they always good enough for you to practice your oral surgery?
So no offense to the people sending the x-rays, because sometimes that's either the best technology they have, or a lot of patients who are in pain and can't bite or cooperate fully can't get a great x-ray to be sent over. Sometimes the x-rays they sent are not digital. The new way to do it is digital, and it's easy to email something that stays at the same quality. But there's a lot of people that have what we call plain film x-rays, which is the old x-ray that you hold up and it looks like a sheet of paper that you can see through. Those don't copy well. So when the dentist sends us an x-ray of that type or a digital that wasn't the greatest, we have to often retake x-rays. Not all the time, but sometimes, because we want to be able to see what we're operating on.
What you need to see is the root, which the dentist does not need to see.
Correct. They don't, well, they do fillings on the biting surfaces of teeth, the part of the tooth that you see in the mouth. So when they take an x-ray, they have to see that part. But they don't necessarily have to see all the way to the end of the root or beyond the root. But I do. I need to know if there's infection in the bone. I need to know what the shape of the root is, because taking a tooth out, actually doing surgery period, is as much an art as it is a science. And there's different techniques and different ways of doing it depending on what you see on that x-ray. They can have curved roots. They can have cysts at the end of the root that you have to remove when you take the tooth out, and you need to see it.
So that would lead you into a panoramic x-ray?
A panoramic x-ray is an x-ray that goes completely around the jaw, shows the upper jaw, shows the lower jaw, shows the jaw joint, shows all the structures that you would normally need to see. And the nice thing is you don't have those little films that have to go inside the mouth that sometimes people can't tolerate. This machine goes around the outside of the head. We now actually have three-dimensional technology called a cone beam. So there are sometimes things that we see in, Panorex is still in 2 dimensions. It's a great x-ray, but sometimes it shows us a cyst or a tumor or the nerve being very close to the wisdom tooth or something where we say, wow, we really need to see this in 3 dimensions to really have the full picture. And that technology a while back wasn't even there, but now we have that also.
Which is true. I mean, it may seem that the root is very close to the nerve, and actually there is space between it.
Absolutely.
Yeah. Okay. Why don't we get into these little guys here?
Okay. So what I brought is a few examples of how we replace teeth. So we'll start with the basics and work our way up. I think seeing the picture is worth a lot. So a lot of people walk around with dentures. And a lot of people walk around without their dentures because it's sitting in their nightstand, because it flops all over the place. We find that upper dentures tend to work better than lowers because they hold in by suction. Lowers hold in by a prayer. And every time you move your tongue, the denture moves around. So this is a lower denture on a plastic jawbone. And I'm going to turn it upside down. And I'm going to shake it. And you can hear it rattle a little bit, but it's not going anywhere. So I don't know if you can see, but there are 2 implants embedded in the jawbone. And in the denture, there is an attachment. And you can actually hear it snap on. So this is an easy and probably the least expensive implant type thing you can do that aids people in chewing. And I think right now, in today's day and age, anybody with a lower denture, standard of care is probably 2 implants or more. And you say, okay, here's 2 implants. What about the or more? Well, here's 4 implants, and I'm going to shake this one. Notice no rattle.
No rattle.
Well, I mean, if you think about it, if you have a chair leaning against a wall with 2 legs, you can sit on the chair, it's not going to fall over. The 2 implant model uses the jawbone to help hold the denture and the 2 implants. The 4 implant model is your chair. It's not using the wall to help hold anything anymore. It's all on the implants. This is harder to get off. Okay, so this is the same looking thing, except there are now 4 implants and 4 attachments in the denture snapping on. I think a better choice. If I had a denture and I was going to pick one, I would pick the 4, but obviously twice as much expense. It's not twice as much surgery, but it's twice as much expense. And so it's a choice that you're making.
Okay, now, once you put an implant in, and how soon can you do this after the extraction?
We can actually, in some cases, place the implants right at the time of the extractions, but that means there has to be bone. So when you're placing an implant, we said it's a very precise hole into the jawbone that you prepare, and the bone has to be able to grow into it. Very small tolerances. So if you're missing a lot of bone, you've had severe gum disease, or the tooth is so wiggly that there's a large space around the tooth that doesn't have bone, you're not going to be able to put an implant right into that site. But if it's a tooth that just cracked off and the root is all there, and you just take the root out and the socket is right there, we can put an implant right into that socket, whether that be to put a denture in, or what I'll show you in a couple minutes is to do a cap so that you just get a tooth back. So we actually have the technology, didn't used to, but now we can put an implant in immediately upon removal of the tooth. But if we have to delay, sometimes there's not enough bone. We take some bone putty, magic stuff. We put it in the tooth socket. It encourages your bone to grow back into the site. And you come back 3 or 4 months later, and now you have bone. And now you can do what you want to do.
Okay, so this really has to be timed with the dentist too,
Yes.
who has the plate made.
Yes.
So if they come back like 3 or 4 months' time, but they still can't get the denture at that time, is that right?
Well, no.
Is there
We
more
have
steps
patients,
to it?
We have patients, you can put the implants in and not necessarily use the implant right away and still have a denture that you wear, maybe using the sticky glue that you can buy at the CVS. And it's not the best solution in the short term, but in the long term, it speeds things along. You put the implant in right away. Sometimes we can load implants immediately. So here's an example of that. It's hard to load one implant immediately because the forces are such that it can loosen, make the implant not heal to the bone. But when you have implants that go across a whole arch, if you have enough of them, minimum being 4, usually sometimes even 6, you can do what's called immediate reconstruction. And it goes by a lot of names, tooth in a day, but
Oh, that's cute.
you have a denture. Now this is a denture that doesn't look like a regular denture because there's space underneath it so you can clean. This denture, as you can see, is screwed into the implants. So it doesn't come in and out. And what you do is you place 6 implants into the jaw, you make the denture, you put it on, the dentist screws it in, sometimes even the same day, and now you have teeth. At some point down the road, we have an option. Not day one, but you can eventually get to this, which is, for instance, you're losing 3 teeth. You can do a bridge. A bridge goes from one tooth to another tooth. A bridge goes from one implant to another implant. So you can put an implant here in front, an implant here in back, let them heal, come back, put a bridge on. This is not a denture. This is the same kind of bridge that you put on teeth. You actually feel like you have your teeth back again. And this is the same type of situation as one tooth. So nowadays, a lot of implants are done for, gee, I'm missing one tooth. I don't want to be without that one tooth. I don't want a big bulky denture. I don't want to have a bridge, which I'll show you here. This is what you have to do to 2 teeth to make a bridge. You actually have to cut those teeth down to little pegs. And if those teeth are perfectly good teeth, bridges don't necessarily last forever. They can get decay, they can get gum disease. So you've now taken 2 perfectly good teeth, cut them down to little pegs, and condemned them potentially in the future to loss to be able to get this bridge on. Now, bridges can last 20, 30, 50 years, but in the literature, the average length of time that a bridge lasts is 10 years.
That's all.
That's it. Now, that doesn't mean you lose the teeth necessarily. You might just need a new bridge. But bridges don't necessarily last forever. An implant can't get decay. It really shouldn't get gum disease. It's kind of resistant to gum disease. The reason that someone might lose an implant years later is just mechanics, overload, too much force going on the implant relative to other teeth. Mm-hmm. I had one person come in one time, had an implant, 15, 20 years later came back. There was only one tooth in the whole mouth hitting. It was the implant. They had lost all their other teeth, or they were loose, and when a loose tooth is moving, it's not taking the force. So all the force was going on the implant, and he said it took about 3 years, and eventually that implant gave out. Well, I mean, it was taking all the force of the entire mouth. But other than that kind of scenario, implants usually last.
Why would you go around with just one?
Hey, people do amazing things. I'm not here to question what people do. I'm here to fix what they do, but I'm not here to question what they do. So, you know, I mean, I think an implant is a lifetime solution in most cases, not all cases, but most cases. Whereas partial dentures, bridges, not necessarily lifetime solutions. They're solutions, but not lifetime solutions. So I think nowadays, if someone has the finances to be able to do a tooth replacement, it's certainly the way to go. And also the patience, because it doesn't happen, usually it's not tooth in a day. Usually it's, you put it in, it has to heal 2 to 6 months, and then you come back and put the cap on it. So there is a delay.
But is there another, doesn't something else occur to, like at the 4 months, don't they take the cap off? If you put a cap on.
If they've put a cap on immediately, which we do sometimes, and so immediate reconstruction nowadays is you put the implant in, you put the cap on the same day, understanding that more of those implants will not heal than if you didn't put the cap on the same day. It has a lower success rate. But a lot of patients go, that's okay, it has a lower success rate, I still want my tooth right away. They put it in right away, and about the 4 to 6 month mark down the road, they take the temporary cap off. At that point, the implant's either healed or it's not. Now you put the permanent cap on. But the patient a lot of times views that temporary cap as a permanent cap. I mean, it looks pretty good, it functions pretty well. The dentist knows it's not the permanent cap. The patient's got to come back and get it replaced. But up till that point, they're still functioning with the tooth. And that's very valuable to people. Sometimes people say, I'd rather do that. The difference is the success rate. So nowadays, we're at 95 to 98%, putting an implant in, letting it heal, coming back and putting a cap on it, or a denture on it, whatever. When you restore them right away, success rates can vary. They can go as low as 75, 80% for certain cases, and they can go as high as the same, 95 to 98% for other cases restored immediately. And that's why you need a consultation. We have to discuss it. We have to come to some decision. But implant companies actually, for the most part, at least the better companies, warranty their implant to heal to the bone. So people tend nowadays sometimes to take more risk because it's warranted anyway. If it fails, they get a new one for free.
Right.
So that's okay. But you have to go through the procedure again. You don't want to do that if the risk doesn't make sense. So that's why experience of the surgeon makes a difference. You have to come to a decision with the patient as to what's best for the patient.
And for all of the procedures, do you not have to have the patient sign a slip,
A consent form.
a consent form?
Well, in surgery
For
we do. At least in
extraction, for
oral surgery we do.
bone.
We were trained in the hospitals. We do a residency, you know, doing major reconstructive surgery and the like in the hospital setting. And when you go to the hospital and you have major surgery, you sign a paper that lists all the risks and benefits of the procedure. And I think oral surgeons have carried that through into their office setting. So pretty much any surgery we do, we go through the risks of the procedure, the benefits of the procedure, all the different ramifications. You make a decision and you sign a consent form saying that you understand all that discussion.
I'm sure this relieves the patient a little bit, but thinking that, you know, oh, none of these things bother, but still you're covered for those things that are way out there that might never occur in a lifetime. But
There's things that happen once in a lifetime. Sometimes we still mention them. Patients get nervous sometimes because of that, but I tell them this is like once in a lifetime. But there's other things that happen more frequently, like infection. Infection, a certain percentage, 3-4% of the time. On some procedures, you can get infection. Other procedures, maybe only 1% of the time. But it's never going to be 0% of the time. And I think people understand that.
okay, now, it would not be kind of me not to mention some of your girls. They're all
My awesome staff.
they want a copy of this tape. So who do we have as office manager?
Office manager is Nancy.
And she is office manager of all the
All
offices?
of the offices. She's based in Meriden, but she handles the day-to-day office management of all of the offices. And there's a business manager too, Joe,
Yeah.
who is not on site. He's off site, looking at his computer. We're in the cloud. We actually were the first multi-office major oral surgery practice in the cloud, and we are able to see what's going on in every office from anywhere. So he monitors in that manner.
So Joe can tell what's going on.
He can tell who's doing what.
Who's doing what? Oh, gee.
Dangerous.
I know it. Okay, and then you have a manager of the assistants.
We have a head assistant, an assistant who usually has more experience. I'm a collector of everybody's best people. Like even if someone applied for a job and I didn't even have an opening, if they were a stellar person, I hire them anyway. I have accumulated some of the most outstanding staff people around.
Thank
And yes, you too. I mean, how many years have you been doing this? Tell the audience how many years you've been doing this.
Oh, at least close to 40
Right.
years.
I mean, I think experience is very valuable. When people have been doing it for a long time and doing it in an exceptional way for a long time, I think you can't minimize that. That's very important to a practice.
You know what I love, though, after so many years of working like this, you know, right now I'm doing the utility rooms, you know, breaking down the trays, setting up the trays, and I love the 2-doctor days where, you know, it's like 1 o'clock before you even think of, is it time
Goes
for
fast,
lunch
doesn't
yet,
it?
you know?
It's busy.
And I love that. And I have fun with the girls. You know, I tell them to get out of my kitchen. I'm baking, and I've got to tell you about that one in West Haven. In the West Haven office, one time I said, "Don't bother me today. I've got a lot of baking to do." The girl at the front desk, she said, Megan, she says, "Well, what are you baking?" And I says, "Cookies." And she said, "What kind of cookies?" I says, "I don't know. I'm going to try sandwich cookies." And she said, "Oh, that's good. What are they going to look like?" I says, "Kind of like Oreos. I'm going to try to get there." So mid-afternoon, of course, I went out to my car and got a tray of Oreo cookies and brought them in. Now, your remark was, did she really make those? But, you know,
I wouldn't put it past you. You could have baked your own Oreos.
Yeah, but I didn't know how to write the name on it. What I'm trying to get to, you know, it's not all business and steam and everything. You know, you can have a little laugh here and there and relax here and there, you know. And like I say, a 2-doctor day, wow, I don't have time to bake, you know.
It can get pretty busy. I think we try to, one of the advantages that we have as a practice philosophy is we try to be one big family. And I mean, obviously, families out there know that sometimes that's hard to do when people can have conflicts. But for the most part, we're a family, and we treat our staff that way. I would do anything for any of my staff members. I think
Really,
they're a very great group of people.
I find them, you know, no matter which office I go to, you know, they're all easy to work with. Pleasantries, you know. So anyways, I not going to have much more time for baking. If there's anything more that you want to add here. As far as the staff, do you know how many?
We had 43. Some are part-time
right?
and some are full-time, but we have 43. But we're about to expand again, so we're going to be at about 50, right around 50, I think.
Wow.
Very shortly.
And working part-time and being busy on 2-doctor days, I'm introduced to these new people, and now I start getting them mixed up, and I have to ask somebody else, what was that name?
We don't have them wear name tags. Maybe we should do that.
You know, especially if you know, if you got personnel that goes to different offices at different times.
Right. Most of our personnel don't. I think most of our personnel are mostly in a given office that they consider their office, but we do go from office to office.
Yeah, yeah, especially the part-timers like that.
Yeah.
You know, and I go, like I say, the West Haven office, that's a real trip. But I don't even mind the travel on that. And there was one day, by mistake, I was so used to going to North Haven office, I got on the Merritt Parkway. Well, I ended up in Naugatuck, I think. Had to find my way back. I mean, it only took me an hour and a half to get to work that day. What a floozy
We were
that
probably
was.
all going, where's Lois?
You know.
Where'd she go?
And I'm saying, where's the office, you know? Oh, but other than that, you know, if I'm concentrating and get on the right highway, I'm okay. It's great to meet all these people, all the staff. They're all wonderful. They're up to par, and it's nice where they can just drop a tray, and I say, out of my kitchen, you know.
See, the nicest thing that I see, and you're part of this, but we have a group of people they're very competent, exceptional actually, in their job, but they're also exceptional in their people skills and compassion. I think patients come into an oral surgeon's office, and for the most part, nobody really wants to be there. I mean, even if you're doing an implant and getting a tooth back, it's still a surgery. No one really wants to be there.
But
And
that's
our
up
job,
to the assistant
well,
to
and the front desk and the
relax
doctor,
them.
it's our job to make sure that when they walk out the door, that they're thrilled to have been there. That's what we want to achieve. And I think the group of people that we have does a really good job of that.
They do. I see them just relax a patient. A lot of time I'll go in and talk with the patient too, and you can see them relaxing, you know?
They sink down
Yeah,
in the chair.
well, that's when we tip the chair back, right? If you call that relaxing. But anyway, is there anything else you would like to say?
I'd like to say thank you for having me on this show, I guess.
It's been a pleasure. My pleasure.
Thank
but
you, mine too.
You have had some awards too. We got a minute left, so you've
We
had
don't
some
wanna do
awards.
that.
No?
Really?
Yeah.
I'm happy. I've won a lot of awards, but I'm proud that I'm participating in organized dentistry. I've been president of the Connecticut State Dental Association. I'm active at the ADA level at the American Dental Association in some council work. I'm pretty active advocating for dentistry at the state level with our state representatives. I think that's something I'm proud of. And yes, there's a bunch of plaques on the wall, but they kind of turn into wallpaper at some point.
I forgot about them. Thank you for coming out tonight.
Thank you for having me.
It's been great. It's already gone by an hour.
Went fast, huh?
Say that. And we're signing off and invite you to join us again next week on The Voice of the People.